So, a 41-year-old male comes with complaints of um, lumpish feeling in the left scrotum. And what we see is nothing extraordinary. We see a mass in the left hemiscrotum in the testes, and this is clearly a germ cell tumor. We're not worried about what that subtype it is. It came out to be embryonal carcinoma. Again, nothing exotic about it. What's more interesting is patient's history. So the patient is a chronic opioid user. He also uses marijuana chronically. And then there was this paper in radiographics which spoke about various manifestations of marijuana, and which is cannabis, and they also spoke about association between cannabis use and germ cell tumors, particularly non-seminomatous type. So that's the image from literature from radiographics. Also, I Googled and I found this paper which says confirms association between marijuana use and non-seminomatous germ cell tumor risk.
Wow, I had no idea. So, how much higher is the risk?
They did not, I'm not sure if they told the percentages, but I'm sorry, I don't understand much of this thing. But it's
Okay. And can you actually show the radiographics paper again? Like, did you take anything else away from that paper? Like that, I was assuming they probably talked about like inhalational marijuana effects and things like that, but they're talking, this whole paper was about marijuana?
no, it was recreational drugs in abdomen and pelvis. And thank you for pointing that out. Yes, they speak about that the odds ratio is 2 to 3.
Got it. Wow. Okay. More motivation to not go down this pathway.
We're probably going to see a lot more patients with non-seminomatous germ cell tumors now.
Yeah, now that it's more legal. Okay, so this patient, I'm gonna withhold history for 1 sec until you, I'm just gonna scroll through once and then you can tell me what findings you see.
Is it perforation of sigmoid or rectum? There's a lot of retroperitoneal air.
Yeah, exactly. So there's a lot of air, even I'm gonna put out on lung windows, a lot of
Can you
air.
scroll back, Aarti?
So it's in the perineum, perirectal area, muscles, even some intraperitoneal air in the subcutaneous fat, and even goes all the way up here, a little bit in the mediastinum.
Sorry, not sigmoid, more so rectum. Sigmoid is not retroperitoneal. So something retroperitoneal. Is this perforation?
Did he put something in through the rectum or?
Good. So I love that you honed down that it must be a rectal perforation, and that's a great point here, which is that a lot of this air is retroperitoneal. Some of it is intraperitoneal, but if you have enough retroperitoneal air, and you can see that like to get all the way up here, this is really a retroperitoneal focused process. If you have enough of that, it can dissect into the intraperitoneal cavity. So anyway, I didn't tell you the history, but this patient actually went for an outpatient hemorrhoidectomy. They'd had bleeding hemorrhoids, and they had several banding procedures that had failed. So they went for a hemorrhoidectomy, and just to show kind of a visual of what that is like basically you have these engorged, like a clump of engorged vessels underneath the surface. Oops. And they will kind of scoop them out and then sew up the mucosa over it. And in this case, I guess they went a little too deep and perforated through the rectal wall. So patient came back with, pain and nausea and had all this perforation. And because it was considered like a macro perforation, there was a lot of air, they underwent a diverting colostomy. So just, not that that complex of a case, but I think it was really good the way that you kind of thought through like, okay, where is this air coming from? This looks retroperitoneal. It's really centered in the pelvis and dissecting superiorly, and so it's probably a rectal perforation. Yeah.
So we have another patient, and when I say another patient, it's on similar lines. So patient comes with excessive nausea and vomiting, and we do a barium swallow. Basically, it's not barium, it's like gastrographin swallow. And what we see here is I have still images. So that's the epiglottis, which is pretty prominent, looks thickened. And if I show you the CT, it becomes more clear. So there's a lot of pharyngeal edema, laryngeal edema. And the patient also has esophagitis. Nothing wrong with the stomach. So basically, this patient also is a marijuana user, and there is something called as cannabinoid hyperemesis syndrome, and that's what the patient had. And because of so much retching and emesis, the esophagus underwent secondary inflammation as well as the epiglottis. So that's epiglottitis because of gastric acid. And that's cannabinous hyperemesis syndrome.
Where are you working at, Yashant?
I know all he shows is he shows like prisoners, drug use, and parasites.
And I think I have the clinical image for this. So that's the inflamed and enlarged epiglottis.
Wow.
Nice. Okay, so this patient, oops, let me take off these arrows, had ulcerative colitis and a total colectomy, ileo-anal anastomosis a couple of years ago.
Volvulus.
Looks like a volvulus.
Yeah, and now has these findings. So we can see that this is the ileo-anal J pouch. So we have, this is the pouch, the two parts of the pouch, and then this is the anal anastomosis. And then it looks like just above the pouch, there's like this volvulus here and comes out here. And I will show you that there's basically two transition points. So this guy coming in and then this one, right? So there's two transition points. So it's like a closed loop obstruction with a sort of volvulized picture. And most of the obstructed loop is up here. So do you have any idea how this could happen? Do you think, do you know how this is actually a kind of known potential complication from ileo-anal J pouch anastomosis?
Didn't get your question.
Do you know how this could happen? Like these patients are actually predisposed to this thing that's happening here. And I'm just curious if you know how what they're predisposed to.
No, no idea.
Okay. So I just learned this from my surgeon. Let me pull this over here. Oops.
We mean to say that, when they have to remove, they go to the same thing which we discussed last time, white line of, so they go until IMA level, release the mesentery. So they create a gap there and then they remove.
Yeah. So basically when you have to mobilize the small bowel. So you have to mobilize the mesentery. So you basically have to like cut through the mesentery and bring that piece of ileum down here, make it into a J, and then sew it to each other. And that makes the J pouch. So this cut edge of the mesentery means that you basically are creating this potential space behind it, and it allows for internal hernias. And that's exactly what happened in this case. Basically, the small bowel, this bowel slipped underneath this hole here and created, it wasn't even so much of a volvulus, it was like a little bit twisted, but the main thing was that it slipped underneath this mesentery into this very small closed space and created this internal hernia. So a couple of teaching points that my surgeon told me about in this case, because he was asking me like, oh, do you think it's an internal hernia related to this mesentery? And I was like, I don't know, it could be. To me, all I know is that it's a closed loop obstruction and needs like, looks like it needs surgery. But it helped with their approach because basically what they had to do was then, take it out, the bowel was okay. And then they sewed down this edge of the mesentery. I asked him why they don't do that already to like prevent this complication. And he said that, it's very, very tricky. There's a lot of vessels here. It can lead to a mesenteric hematoma. It can also lead to ischemia of this loop. So generally they don't like to really sew that or touch it. But in this case, like if this, rare but known complication happens, that's what they do. And then he told me a few other interesting things that I didn't know about. He said that one, the rates of doing ileo-anal J pouch anastomosis are going down for two reasons. One, these actually have a lot of complications. They're very complex to do, and they have a lot of complications, including leaks at the anastomosis, at the J end, etc. Two, they're getting better at rectal sparing. So now keeping the rectum, and actually then you can just do an ileo-rectal anastomosis, not a J pouch, and that's a lot easier procedure. Higher up, you're not like deep down into a narrow area of the pelvis. And then also the biologic agents have gotten a lot better. So these patients are just getting less surgery in general. So there's lower colectomy rates even in patients with ulcerative colitis. So I just thought that was interesting. He was talking about it in the context of like surgeons are not getting enough training to do these procedures. But good for the patient that they're getting better, inflammation control and that kind of stuff. So yeah, that was what they did here. So they went in, they took the bowel out from underneath the mesentery, tacked down the mesentery, and they were able to save. This bowel didn't have signs of ischemia, but because of the closed loop, they had to go to surgery.
That's a great case, Aarti. Thank you.
Yeah.
Is that also the, sorry.
I
Is
don't
that-
think it like, fully mattered that it was specifically an internal hernia, but he just said that like it helped for their planning to just know like, okay, we're gonna have to probably tack down the mesentery, we'll have to mobilize the mesentery and the J loop, etc. What were we gonna ask?
Is that also the reason like how we do Roux-en-Y and we do pre-pyloric and post-pyloric and that also gives rise to the Peterson's hernia or something because we're creating defects in the mesentery essentially. Is
Yes.
that also the reason? Okay.
Yeah, this is not a defect in the mesentery. You're like basically cutting the entire mesentery and then pulling the bowel down, but then like behind that cut edge, there's a space. But yeah, same thing.
Okay, thanks. So nothing exotic about this case. It's just reiteration of what we learned 2 weeks back. So this patient has this lesion here. And it's not as important what it turned out to be. Basically, it turned out to be not GIST, not carcinoid, but solitary fibrous tumor. But more important is the teaching point that it is so close to the gastroesophageal junction that because it involves much more complicated process, so the surgeon chose to observe this and not to operate this. Something that we learned from Shekhar's case, I think 2 weeks back. So I think that's about it for this case.
Yeah, so reiterating teaching points about solitary fibrous tumors. I've never seen one in the stomach, but my impression is that you can get them anywhere. Most common places are going to be in the pleura and the retroperitoneum. They can be multifocal. They're all considered premalignant. So you have to follow them for 10, 20 years because they can metastasize even after 10 years. And you can get them I've seen some interesting ones along the liver, like along the falciform ligament, the capsule of the liver. So I think anywhere you have that sort of like capsular or ligamentous areas, those are possible as well. And then they can produce the insulin-like growth factors so that you can get hypoglycemia. But yeah, I could see how a small one like this, like you could just observe it and see if it grows. The trick with the GE junction tumors is like One, it can cause obstruction if it starts growing. And also two, if it actually involves the GE junction, you might have to do a total gastrectomy because it could involve the vagus nerve and then you'd have to lose your whole stomach. So
Aarti, years back, we had a case of myeloma who had a big liver lesion. I've shown this case before some time back, and we kept thinking it's extramedullary disease, and it didn't get better, so they biopsied it. It turned out to be a solitary fibrous tumor. And then
Oh,
we've
wow.
seen another one, couple in the pelvis.
Yeah, I've had
Solid
many
masses.
at this point, so I'm just like, I'm never surprised when I see them. But recently I had a consult of like something that was like hanging off of the liver. It was like almost like from the liver capsule, and it had all these dark areas and it had some bright areas too. So like whenever I see dark and bright, I was like, oh, sclerosing angioma, but it didn't really make sense that it was like hanging off the liver. They ended up taking it out and it was an SFT too. So my takeaway too is like on MRI, they can be really bright or they can be really dark and dark and bright. So I think like when I see either of those ends of the spectrum, not like evil gray, but something that looks really like solid, encapsulated with like either pretty bright or pretty dark, I always think about desmoids and solitary fibrous tumors. And it makes sense because they're both of like that fibrous spectrum where they either have a fibrous part dominating or like a collagenous part dominating that make it either dark or bright. Okay. So this patient, so first of all, any observations about their liver?
Biliary
Soft tissue.
ductal and soft tissue.
Periportal soft tissue.
Peribiliary and periportal soft tissue.
Yeah, okay, good. So there's some soft tissue here. There's some soft tissue here, maybe along here. And then the bile ducts are dilated all the way out here, right? But it looks a little weird, right? Like say you had a hilar cholangiocarcinoma, wouldn't you get more biliary dilation, like even of these ducts?
Is this IgG4 or that other condition that you showed that last week?
What condition did we show?
You showed something in that talk that you did last week.
Yeah. Yes.
I don't remember the name. I wanted to ask you a question about that.
Perfect. Actually, this is the perfect. Yes, this is the entity that I showed in my talk. So this is going to be how much did you pay attention?
I did pay attention. I just don't remember the name.
Okay. So this is a scheme. Well, okay. So first of all, let me just show you this. I didn't tell you one other thing, which is that this patient has had a liver transplant. So if you just saw this in a like, non-liver transplant patient, you might think anytime you see bile ducts that go all the way to the periphery of the liver like this, right? This is really abnormal. Normally you only see really the central confluent ducts. So this like looks like sclerosing cholangitis, right? There's this subtle beading of these ducts. You see them all the way to the periphery. They're very like subtly beaded, right? So non-liver transplant, this looks like sclerosing cholangitis. Post-liver transplant, this is secondary sclerosing cholangitis in the setting of ischemic cholangiopathy. And what I talked about in the talk was that I used to always think ischemic cholangiopathy was, patients who had had hepatic arterial thrombosis. But this is there's now this microangiopathic ischemic cholangiopathy. It was a radiographics paper. This is the paper that I talked about. It's from the Mayo group, Maria, who's been on our case conference before. And so it's ischemic cholangiopathy, and it's specifically in patients that have donation after circulatory death, so DCD, which is different than DBD or brain death. So these circulatory death patients, their heart stops, so their liver gets ischemic before they even, might, put them on a pump or put them on, get them transplanted. Nowadays, they do put them on these pumps that they think that the rates of ischemia are going to be a little bit less. But anyway, the interesting thing is that there's 4 types. So first of all, just a couple of cool graphics in here. This is what is happening. So basically the liver, there's cold and warm liver ischemia and then reperfusion. And because of that, there's bile stasis, bile toxicity, and it leads to this kind of cycle with inflammation, fibrosis, and then finally stricturing. And that's where you get this like secondary sclerosing cholangitis picture. And there's 4 types. Diffuse necrosis. This is a very severe. It's usually pretty soon after transplant, and they almost 100% need retransplant. Progressive, multifocal progressive, about 65% will need retransplant. confluent dominant, where you could try to treat it with a stent. A lot less of these will need retransplant. And then the minor form, where it actually resolves over time. So I was talking to my transplant surgeon about this, and he was like, yeah, that's great. You've got these 4 forms. All I know is usually basically the patients present with like their bilirubin starts rising, their alk phos starts rising. They know there's a biliary problem, especially if they've had a DCD liver transplant. They assume that it's basically ischemic cholangiopathy, and they try to put a stent in. That's the only solution they can really do. They can give some meds, but basically they go ERCP and put a stent in and hope that maybe there's a dominant stricture that they can alleviate. But if that doesn't work, then they know it's one of these 2 forms, which we can really nicely see on this particular example. And a lot of those patients will end up needing a retransplant. So this patient is now, they're waiting for a retransplant, but looks like a very, a nice or a good example of PSC, but in the post liver transplant, that's going to be secondary. And I like, for PSC, I like looking at the venous sometimes if the MRCPs are not like as clear as this one, where you can see like these dilated ducts going to the periphery, but then they kind of like, you can't trace them all centrally. So you know that there's a lot of like strictures that are kind of coming and going. And I feel like we see it nicely on like these venous phases. Like there's a duct, it came, it went, that's the example of a beaded duct. And then here's our clue. Any questions?
No, thank you for teaching.
Yeah.
Right. So, I mean, this is not a very subtle case, as you can see, the abnormality.
Like hepatosplenomegaly with lots of splenic lesions?
Yes, hepatosplenomegaly, a lot of splenic lesion. How do you think the liver texture is?
Also see lots of little liver lesions.
Is it
Liver
sarcoid,
lesion.
Tarun?
Kader is guessing sarcoid, which was
Sarcoid, yes. Why sarcoid?
Periportal nodes.
Periportal nodes, yes, exactly. And I don't know if actually the way we made this diagnosis was of course liver, but look at this. This is very classic.
Oh yeah,
Fissural-
nodular along
nodular
the fissures.
Yeah. So this is a young patient, had elevated GGT, alk phos, bilirubin, abdominal pain, constipation, kind of that abdominal kind of a presentation. So sometimes sarcoid may not have like, I mean, it's a multisystemic disease. So look at this, the liver is almost reaching up to the pelvis. So this patient presented with abdominal manifestations, and see this vein here. You can see this like a almost like a pelvic congestion because of this lymph nodes kind of compressing the vein.
Nice.
Yeah, so that was a cool case. I thought that we don't see that many abdominal manifestations, and this was kind of rare.
Yeah, very
All
neat.
right.
Do you know if they had a chest CT with like the mediastinal hilar lymph nodes or anything? Or I know you saw the one bases.
Yeah, so all I have is a chest radiograph. I
Okay.
can show you that. And so there is some kind of looks like hilar lymphadenopathy. Not much of mediastinal nodes that I can make, but you can see the kind of more reticular type of pairing kind of parenchyma. But yeah, there is definitely hilar lymphadenopathy.
Nice.
So middle-aged person comes with acute abdomen. I can scroll again and I can show the other planes as well. The area to focus is hepatic hilum.
Wait, is there like what was that bowel loop that's going up? Yeah, that right there.
Transverse colon.
Why is it so posterior like that?
Exactly. So This is foramen of Winslow or lesser sac hernia, internal hernia. So there should not be anything between portal vein and IVC. So that's the potential space, which is the foramen of Winslow or which leads to the lesser sac. So if we see anything here which is going to be abnormal, we sometimes see lymph nodes, but this is just marked dilation of the space, and the cecum is here. Even appendix is here, but appendix is not abnormal. It's just a cecum here. I'll also show this on coronal. So we are tracing the transverse colon, and it goes inside the hernia. So there's kind of closed loop herniation with cecum inside, and then ileocecal, that's the ileocecal junction, and that's the ileum, which is normal, which is coming out. So foramen of Winslow hernia.
That's amazing. That's a beautiful coronal.
Thank you. Treatment is surgical. So this patient was surgically treated. Interestingly, this is because of congenital defects, but the patient do not present immediately after birth. They present in their 40s or 50s.
And the whole Middle Eastern thing was a red herring, like had nothing to do with it.
I think he said middle-aged.
Middle age.
Oh, I think you said
That's
Middle Eastern.
because
That's
even
like,
initially I heard Middle Eastern also, and then I said, no, that's not right. So that must be middle-aged.
oh wow. I was like,
Sorry,
okay,
Max.
we're gonna go down the like a kind of caucus, just like I don't know what are we doing. Cool. Okay, so patient presented with hematuria.
Adenocarcinoma of the urethus.
Urachal mass.
Yes, 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 yes. I just thought this was a really, really nice example. They can tend to calcify since they're adenocarcinomas, although urothelial cancer can also calcify. And the interesting thing about this one is that it's actually multifocal. So there's this dominant one of the urachus. You can see the rest of the urachal remnant, the vitelline duct going up to the umbilicus. But they also have some down here. I tried to look up multifocal adenocarcinoma, and there are some case reports. Our theory in this case is that like maybe these are kind of like drop mets, like some of the cells kind of dropped down and started growing along the wall here. They're not connected to the main mass, but yeah.
One thing about urachal carcinoma is, like, as Dr. Menias keeps mentioning, that we always like talk about these, but nobody talks about prognosis. Prognostically, they're like super, like really, really bad.
Yes, and actually, like this patient has lung mets, and so they're just on chemo, not they're not resecting it at this time.
So just sclerosing cholangitis in another patient. The reason here was hepatosplenomegaly and recurrent episodes of infection, which led to sclerosing cholangitis. So we see some narrowing and then dilation. So something similar to PSC, but it is not PSC, it is secondary cause.
Yes, very nice. So PSC, primary sclerosing cholangitis, often like 30-year-old males, it tends to predominate, and their ALK phos will be elevated out of proportion to the other labs. And then secondary can be from a lot of different causes. So I just showed the ischemic cholangiopathy in post-liver transplant. There's also IgG4. There's other, I think, autoimmune and some medications that can cause sclerosing cholangitis. So anything that's going to be causing like some inflammation and eventual ischemia of the bile ducts can give you this kind of beaded stricturing appearance.
Sure.
Including chronic infections, like you were saying, like repeated from a hepatococcygenostomy.
Yes. I can also show periportal, what do you say, soft tissue in case of IgG4, if you would like to see.
Okay, sure.
So we see the subtle soft tissue around the periportal space compressing the biliary ducts again here. So this is a proven case of IgG4 in the periportal space causing sclerosing cholangitis.
And you diagnosed it on ultrasound?
No.
Oh, got it.
I just have ultrasound picture here, but no, it was The patient had multifocal involvement, including pancreas, and pancreas was biopsied.
Nice. The one thing about IgG4 sclerosing cholangitis is that I think like over 90% of them will have pancreatic involvement too. So in the other cases of sclerosing cholangitis, usually pancreas is totally normal, but IgG4, you should always look, like if there is also a pancreatic abnormality, that should be your red flag that it could be in the setting of IgG4.
True. Yeah, multifocal is the word when you think of IgG4.
Yep.
I can
Okay.
show another one, quick one.
Yeah.
Okay, so this is a young patient who has acute abdominal pain. And it's like a lower abdominal pain. Going slowly. So initially, when I was checking out this case, this was one of our call cases. I was almost about ready to pass it, and I really didn't see it. And then I asked that, where do you?
The bowel is kind of, can you go down again one more time? And go back up, sorry.
Mm-hmm.
Why does like the the sigmoid colon like disappear?
Right over here somewhere. I can see. I think it's here.
It's fine. Okay.
Yeah, it's fine. So I just asked the resident that, okay, where is the pain? So then he kind of investigated and says that pain is anterior lower abdomen. So then we kind of gave another look to it.
Oh, the urachus.
Yes.
Oh, wow.
So
Wow.
look at this. And so this was a sagittal.
Yeah, there's like a infected sinus or.
Yes, correct. And from very normal it became suddenly very abnormal, and then this is a follow-up after several weeks. Kind of
Wow.
subsided.
Was
Yeah.
there was no discharge coming out of their umbilicus?
No, there's no discharge. So I think it was
So it's
more
more
on
like an
this.
infected
Yeah,
diverticulum.
yeah, exactly.
Cool.
So, but it kind of was inflamed all the way right here. You could see the stranding over here.
Wow. Nice.
Yeah. Yep.